Okay, thanks, Dr. Wittstein. So I'm going to talk a little bit about elbows, a little more specific to baseball, and at least it has a surgery named after a baseball player, which we'll talk about. I'm sure most of you are familiar with. So these are the four topics on elbows that we're going to talk about today. The ulnar collateral ligament injury, which most of you know of as the Tommy John injury. Lateral epicondylitis, tennis elbow it's called. Then there's little leaguer's elbow, and then medial epicondylitis called golfer's elbow. So they each have sporting names, which makes them interesting for our sports medicine doctors here. So as painful this may be, this may cause you flashbacks, Bill, to when you were pre-med years in college. This is some anatomy. We'll talk about just enough anatomy to know what we're talking about. So the Tommy John injury we're going to talk about has to do with the elbow ligament called the medial ulnar collateral ligament, this side of the elbow, and it's represented by this red circle in this triangle here. The anterior bundle is the one that's most prominent. Then we need a little bit about bones, because the tennis elbow and the golfer's elbow involve either, in the golfer's elbow it's the medial epicondyle, so it's the bone down here, which is also the same side as the Tommy John's ligament is. Then the tennis elbow is on the outside, or this side, which interestingly golfers have more trouble with tennis elbow than do golfer's elbow, but that's a separate topic. And then the golfer's elbow, again, is on the inside here, and is often brought about by hitting fat shots or digging into the dirt. I'm sure that never happens to you, Bill, right? So, but that's one way you can get that, and other repetitive things. Now, these are not limited to golfers and tennis players and baseball. In fact, many of them are not associated at all. But they have this name because these are the athletes that have particular problems with it. So we'll talk a little bit first about the Tommy John injury and how it occurs and how it came to be called this and how it's treated. So again, here's the ligament. If you take it's on your right in front of your funny bone on the inside of your elbow. The ligament runs from the distal, the end of the humerus here, down to the elbow joint here on the other side. And so we call them MUCS, that's medial ulnar collateral ligament injuries. They come from overuse. Usually, how do we diagnose this? Usually the pictures will tell us they have decreased speed, they have some pain, which is a late cocking. We'll show you the throwing phase. So the late cocking is back here. That's when they feel the pain. Sometimes they have numbness in the ring and small fingers associated with it. And then there are exams that we do, which I'll show you in a moment. These are two of the tests we do. We basically, you may have heard of having a medial collateral ligament injury to your knee, where you can open the knee up from the inside. The same thing with the elbow. If you stress the elbow, try to bend it to the side, it'll open up and cause pain when one does this. There's a test called the milk test, which is basically doing the same thing. It's called the milking test because you're grabbing the thumb like this, and if someone tries to straighten it, you're pulling here to see if that causes pain. And usually the pain occurs at the more flexed positions through about 30 degrees to about 120 in here. And that causes pain where this thumb is shown here. We have to use other modalities to study this. We use MRI arthrogram, much as we do in the shoulder. And this is an MRI showing this is the humerus, and this would be the inside or medial part, and this would be the outside. And the dye here leaks down and shows that this is a tear here where you see this black arrow in the red circle. And then sometimes during arthroscopy, if we're looking in the elbow, we can make the diagnosis. And in that case, the joint opens up. If you look in the joint and you stress it, you can see there's more laxity between these two bones than there should normally be there. So this was so common in baseball, and it became famous because a famous baseball player, Tommy John, had surgery on his elbow by an orthopedic surgeon named Dr. Frank Jobe, and he did the first reconstruction of this on a pitcher. He's out on the West Coast near L.A., and so Tommy John became famous because he returned to baseball in 1976. In the first season back, he was 10-10. Now, I don't know if that'd make you famous anymore, but at that time it was. And he pitched 26 years and retired in '89, so he made it for another 13 years. So that made the surgery famous, and Dr. Joe as well as Tommy John, probably more famous because of the surgery he had. So the valgus instability, that's another name for this, actually was originally described more in javelin throwers, same mechanism, throwing something overhead with a large force. But you see it in other injuries, other sports, tennis, volleyball, football, most of them are chronic overuse. You don't usually say, someone goes, oh, I just tore my ulnar ligament like an ACL or something. It doesn't usually happen that way, though sometimes it can, but that's rare. So part of the problem is that there are two things going on at least. But when one throws with one's elbow back like this, there are two things going on. One side is getting stretched. That's the side where the ulnar ligament is, the Tommy John ligament, and the other side is getting compressed. And this causes all sorts of problems in baseball and throwing, and it causes the symptoms that we'll see as we go. So you saw something about bad throwing mechanics, but you can see in this cock position you put a lot of stress on that elbow. Similarly, if you don't have your arm down your side, but it comes over the top, the elbow is not getting so much stress because you're coming straight over. So that's the better mechanics that you have. And so a lot of this is practically an epidemic now in baseball. I've seen it in little leaguers even. We've seen it a lot more in high school than we once did. And it certainly it'd be hard pressed if you go to a college, they have a good team. There'll be several players who've had the surgery already. It's quite common. And interestingly, there's sort of a street lore that if you have your Tommy John surgery, it'll make you a better pitcher. As there's someone who came back and said that supposedly that was the case. He threw harder. That would be a misrepresentation of the surgery, and I wouldn't recommend you have that. But that's sort of what some of the young baseball players think. And this is a picture of the surgery, how it looks, sort of incision. This is an open surgery. It's not done arthroscopically yet. It's actually not in the joint. It's on the side of the joint, so it would be hard to do it arthroscopically. And there's the ulnar nerve right behind it, so it makes it a little more treacherous for arthroscopy. It's a repair of a ligament. You can take the ligament from your forearm, or you can take a ligament from your knee and make a new ligament. And this is another diagram. This is Tommy John up here. And this is another diagram of the sorts of, there are different ways you attach a ligament to the bone, either through tunnels, drill holes, or you can insert them with two tunnels like this. There are different mechanisms of doing it. And this is another picture of the graft. So obviously, as Dr. Wittstein said, we don't want to have to treat all these, and hence the reason we're doing studies and trying to prevent these and diagnose them early on. Now, switching topics to the younger group, which is where the prevention would be more likely to be effective. Once again, here's the younger pitcher or thrower, and these are the problems. In younger throwers, that we're talking about Little League and all, their growth plates are still open. So that's a big problem because those joints are not made to take the stresses that baseball requires, at least the way we play at this day and age. So you have growth plates up here represented by the blue, and they get a lot of stress. So in the case of a little leaguer, they have pain on the inside of their elbow. They often are stressing this side, the growth plate here, and it can open up just like you saw on the shoulder. It can spread. On the other hand, on the other side, on the compressive side, these two bones are getting pushed together, and it can cause damage to the bone growing here. And one of those problems is called OCD lesions, or Osteochondral Defect. And this X-ray shows the sort of thing we might see. So down here is this bone called the capitellum, which is represented here. And instead of being solid white, you see it's got some black in it. And so it's basically, we call it osteochondritis dissecans, means drying of the bone. That's not technically correct, but the bone is losing its blood supply, and sometimes pieces break off and collapse. It's called an OCD lesion. Here's a 3D reconstruction of what you might see. And this, you see this in young Little League type and junior high age pitchers and throwers. Hopefully before they have that sort of problem, though, they'll have pain on the inside of their elbow. It's called Little Leaguer's elbow, much like you see it in the shoulder, Little Leaguer's shoulder. And in this case, where the growth plate's shown here, this is what the growth plate will look like, this line, the dark line between the bones. There will be separation. This piece will pull off, and just like you would see the spread in the humerus, and so it'll cause pain. And the treatment for that, of course, is some rest. If it separates more than 3 or 4 millimeters, sometimes surgery is indicated to reattach that. But usually they'll heal with rest and the result of bad mechanics and too much throwing. Now, another place in the elbow that gets stress is the olecranon, or the tip on the back. Again, there's a growth plate here, and the treatment first is prevention. Again, not throwing too many times, having pitch counts not just in games but in practices, how many times one throws and how hard, what type of pitches they throw. And in rare cases, we have to operate on these and put something as awful looking as this, which you probably don't want in your 12-year-old son's elbow. But this is when they won't grow, they won't heal back, or there's too much use. Then you can have this OCD lesion we talked about, or the elbow. You can have to fix that either by you lose pieces that break off, or you have to fix them, and these are some examples of that. Here's an example of an arthroscopy with the osteochondral defect. This would be down this direction where the arrow is going this way, and the larger portion is up at the end of the humerus is this way, and you can see there's a big defect. This is a piece that is missing, and this is from too much throwing, osteochondral defect. And those are treated various ways. If they're still attached, just loose, we sometimes put an absorbable pin or screw in it. If they've come off, if we can't reattach it, sometimes we take grafts from other places in the body and put new bone plugs back in. So, but again, the key is prevention and avoidance. How do you do that? Coaching mechanics, pitch counts, avoiding overuse, 3 months off a year if you're a throwing athlete, and no curveballs until skeletal maturity. In a male, that's like 14 years of age, which you'll see is violated more commonly than we would want. And the proper technique has to be taught. A lot of advocates who have followed this for a long time want the radar gun, for example, to be banned from baseball in the lower levels, because what kid doesn't want to know how fast they're throwing? That means they're throwing too hard if they're paying attention. And I'll tell you, because I take care of some of the high school players in a town, that they all know how fast they throw. They can tell you, and they'll tell you the number they need to be in college, 88 miles an hour. That's how much you have to pitch as a senior. Because I have a gentleman who I treated for his hip, but he's a pitcher, and he knows all the numbers. He's known them for a long time. He knows how fast he throws. So if you know that, it's just like scoring in a test. Everybody wants to score high. They want to throw hard. So that's how these injuries occur. So there are a lot of ways, technologies we have to treat this better than we used to. Elbow arthroscopy is one way of doing this. This is a normal elbow. This is an outpatient procedure. Make poke holes like in a knee or shoulder or hip nowadays. Look inside the joint. We don't have to make large incisions, and we look in to see if there are things that are problematic. And these are some of the things the elbow arthroscopy can help. Sometimes there are loose pieces broken off. This would be an older elbow, not a younger one. This would be a pitcher, and he's in his 40s or 50s perhaps. Pitchers, another thing that baseball pitchers get is in the back of the elbow. When they follow through, this snapping action at the elbow will cause a reactive bone spur in the back. Sometimes we have to go in there and burr these off or remove them. And then some of these pitchers, almost all of them, don't have normal elbow straightening ability and get contractures. In other words, they can't get all the way straight. And we have to release the contractures if we can't prevent them by therapy or stretching them out. Now, switching topics to another one is tennis elbow. Now, almost everybody in the room probably had some variation of this, where your elbow hurts on the side here. Hopefully it went away, but often it can be nagging. Tennis players get it, and the culprit generally thought to be poor backhands, but it's more common otherwise. It's an injury to the extensor carpi radialis brevis is the name of the tendon, one of the tendons that pull your wrist up, and it attaches to the side of the elbow there. And there are a lot of ways of treating that. Basically, RICE, which we use in all sports medicine, means rest, ice, compression, elevation, physical therapy. There are braces that we have people wear, as you can see here. Anti-inflammatories like ibuprofen and Aleve. Tylenol is another one that can be used. And rarely surgery. Now, you'll see I didn't put injections there, which is probably the most common treatment for it. That's very controversial, and more people who study it longer we're less in favor of injecting these in cortisone shots than we once were. And they'll relieve your pain. It doesn't cure anything. It can cause hypopigmentation of the skin, and generally they're to be avoided. One of them, maybe one shot if you're in a lot of pain, miserable, is reasonable, but more than that, it's really not a good idea. We do, besides the braces, or stretching and strengthening exercises that are done. If we get x-rays of a painful elbow, we might suspect tennis elbow. Sometimes we see calcification in the soft tissues, as you see here, and now we have a newer technology, ultrasound. I think we spoke at the last meeting using. MRI is another way, but it's an expensive way. You can see tears where the tennis elbow tendon attaches. That's represented by the black spot here. So for those that are recalcitrant to the conservative treatment, we do arthroscopic surgery. Here again, we usually do them with the patient upside down or on their side, so that we're looking at the elbow in this way. It looks like a knee in some respects for arthroscopists. And we look in the joint. We work through here. This is looking in the front of the elbow. This would be the back. And if we look in there, this is the capitellum where we saw the lesion before. There'll be tearing, we can see. This is marking it with a needle, and then we come in and release the torn tendon and debride the tissue that won't heal. That has the advantage as opposed to the open surgery, which is portrayed here. It hurts a lot less. You don't have to wear braces afterwards that you might wear with this, and you can go back to work sooner. This more commonly takes 6 to 8 weeks of protection versus a few weeks with arthroscopic procedures. So then, last but not least, in this, I know Cooperstown's a town of baseball, but there's a lot of golf around here, as you know. So golfer's elbow is a common thing. It's on the inside portion of the elbow, near the ulnar ligament where the Tommy John ligament is. Ultrasound's a good way of diagnosing that. This red line shows you the tendon that's torn from where it's supposed to be. This is the green line where this is supposed to be. It's torn from there, and this is degenerative tissue here. Golfers get it again if they hit with their back arm in this case. And we can see the size of defects. We can measure them with ultrasound if they're not getting better. With the treatment is similar to tennis elbow. It's a matter of stretching and strengthening, good mechanics. You might want to certainly talk to your golf pro for some instructions so you don't hit so many shots in the dirt. The treatment is very similar. You use a brace. This is one kind of brace you get off the internet. You rest, ice, elevation, strengthening. We use cortisone shots more commonly in the medial epicondylitis because we don't have as good other treatments, and that can relieve pain, but it's only a brief pain limiting procedure, not something that cures it. Now I'm going to talk just briefly about PRP because most of you who have an injury to your tendons have probably heard about it, and I have a slide on that. And people are having that injected in the elbow. That's called platelet-rich plasma. And it's been very popular recently because athletes have given testimonies of being injected with their quadriceps tendon, their rotator cuff, with this sorts of thing. It's from their own blood and helping them miraculously play. But if it doesn't go away, the treatment again is surgical. In this case, it is an open procedure, and one takes out the torn tissue and repairs the other healthy tissue. This is the PRP. This is what platelet-rich plasma looks like. You basically draw some blood out, you spin it down, and this is the plasma, and these are the platelets, and this is the part you want, and this is taken and injected into one's elbow. This is a pitcher who gave a testimonial. I would say the science is not good for this, but it's very, very commonly done all around the country, particularly by athletes, and a lot of people do it. They believe it helps. The theory is that it would help. It's sort of like stem cells, if you were. Well, that you put those where they're degenerative cells and try to get new healthy ones to grow. And that's the theory. The studies haven't borne all that out yet, but it's used in a lot of tendon problems. So that's pretty much with the talk on elbows and shoulders tonight. We'll be glad to take questions. Anybody has questions, comments, or observations, the rest of us.